Welcome to Corium. I'm Brian Gilberti, and today we're discussing a physiological paradox, and that's the patient who's drowning in their fluid but has a heart pumping harder than a marathon runner. And we're talking about high output heart failure. And joining me today to break this down is one of our chief residents, Dr. Nico Gonzalez.
Thanks so much for having me. I'm so excited to be here and to be part of the podcast.
We're happy to have you. Now let's jump straight into this. Why don't you paint the picture for us with a case? Tell us what these patients might look like when they come in.
Yeah, let's paint the picture. Let's picture a middle-aged male, has a history of ESRD, has hypertension, some other comorbidities, who's presenting for shortness of breath. But the kicker being that he had HD this morning. He had his full session, lasted the entire session, and is now coming in, despite that, still out of breath. And then describing that over the past week, he's been having worsening shortness of breath. He is on HOMO 2 normally, but maybe needing to increase that at home, at rest, and with exertion. And when going to prior dialysis sessions, was saying that he wasn't really feeling better after those sessions either. When coming into the emergency department and you're evaluating him for the first time, you're seeing that this patient is in respiratory distress. They're tachypnic, they're uncomfortable, they're diaphoretic. You're examining them, you're listening to their lungs, and you're hearing rales in all lung fields. And you're noting that they're pretty significantly edematous all over. You're noticing JVD, you're noticing pitting edema into the mid-thighs. But the kicker being that on exam, their extremities are still warm and perfused despite all of this edema you're noting. And then getting some lab work up, you're seeing that their heart's hurting a little bit, their troponins a little bit up, their BNP is significantly elevated, and maybe a little bit anemic.
And we have a patient who looks wet and congestive, but they're warm with this bounding pulse in their extremities. Now, walk us through this pathophysiology, right? It's very unique. How is this different from your typical heart failure that we see all the time in the emergency department?
Absolutely. And so I think when thinking about classic heart failure, right, is low output, high SVR is the main thing you got to think about. They're low output and they're clamped down. And so when thinking about that, it's classically separated into maybe systolic or diastolic dysfunction with an increased SVR. But with our high output heart failure, you're having normal cardiac function with a decreased systemic vascular resistance. And that's basically either due to diffuse arteriolar dilation or from possible bypass tracts, and you're bypassing your arterioles and your capillary beds, and then leading to further activation of a bunch of different neurohormones that's going to lead to further systemic vasodilation. When kind of getting into the weeds of what that's truly defined by, it gets more into our specific parameters. And so the definition of this high cardiac output state would be a cardiac index of greater than 4 or a cardiac output of greater than 8 with the systemic low vascular resistance. When getting back into what we started this podcast with, this hemodynamic paradox, again, it's this low SVR leading to ineffective arterial blood volume that then leads to activation and kind of firing of a bunch of different systems that leads to a hyperdynamic heart that's pumping against zero resistance and then ultimately leading to your patient drowning in their own volume.
Yeah, a really distinct physiologic state, one that we don't really see all that often in the emergency department. And we need to be thinking about the specific triggers here that drop that SVR or that drive that metabolic demand. So tell us what's on your differential. Walk us through your thought process when you see these patients.
Perfect. Yeah, absolutely. When thinking about high output cardiac dysfunction and high output heart failure, that is essentially the question you should first be asking yourself, right? It's what's causing the underlying disease process, because the underlying etiology of this type of cardiac failure largely dictates the signs, the symptoms, the evaluation, and ultimately the treatment of what you're going to be using to help fix these patients. And so when I'm thinking about the differential diagnosis of high output cardiac failure or high output heart failure, I put them into two main categories first in my brain. The first category being an increase in body's demand for blood from increased metabolism. And then the second one being peripheral vascular changes. And so whether that's bypass tracts or increased in systemic vasodilation, arterial dilation, and a decrease in SVR is the first two buckets I put them in. And you can then further subdivide them, right? In the first bucket, in this increased body demand, I put that into metabolic demand is where my brain first goes to. And so when we're speaking of metabolic demand, the main two cases that you'll see this in really are myeloproliferative disorders and then hyperthyroidism or your thyroid toxicosis. And with regard to the myeloproliferative disorders, it's mainly linked to an increase in cellular metabolism and high cell turnover. This basically causes this increased metabolic demand and then ultimately leads to a decrease in systemic vascular resistance. The one I think we're going to see more often than not is more so maybe this hyperthyroid case and the thyroid toxicosis. And again, that intuitively makes sense in my brain, right? The increase in circulating thyroid hormone is going to affect both cardiac and systemic tissue. From a cardiac standpoint, you're going to have an increase in cardiac contractility, you're going to have an increase in heart rate, and then from a systemic standpoint, the increase in cellular metabolism you get increases your cellular waste products, causing a reduction again in systemic vascular resistance. And so that's the metabolic kind of branch. Now going back to our other bucket, our peripheral vascular effects, the first one being systemic vasodilation. And so we see that in a bunch of cases. We see that in cases like cirrhosis, right? We see that in cases like sepsis. We can see that in cases like beriberi, which is one that I want to emphasize because maybe not one I think about often, right? Our decrease in thiamine is going to lead to a buildup of these other byproducts, pyruvate, lactate, then again leading to our systemic vasodilation. And then chronic lung disease, believe it or not, is also going to maybe cause that as well, with the chronic hypoxia, hypercapnia, driving a reduced systemic arterial resistance kind of state, again, kind of leading to these peripheral vessels getting blown out. And then lastly, being our shunting in the form of arteriovenous fistulas that are either congenital or acquired.
Now, Nico, you kind of hinted at this before, but the most common cause of this is going to be our patients coming in with AV fistulae. This is going to be the most common driver in this dialysis patient population. So let's now drill down on that. How does the access site cause heart failure? And what's the bedside test that we can use to confirm it?
When it comes to like an AV fistula site, right, the steps of how that comes to cause high output heart failure is threefold. And it really breaks down into the phases of change. And so I like to think about that in the acute phase, the subacute phase, and the chronic phase. And so when speaking about the acute phase, you get an immediate decrease in your SVR the minute you make the AV fistula site. The decrease in this total peripheral vascular resistance is due both to the changes made by that site and then later changes you get in systemic vessels. Once you make that AV fistula site, you're going to have an increase in blood flow and shear stress through that site. That's ultimately going to lead to your vascular endothelium releasing nitric oxide and other endothelium-dependent relaxing factors that then further dilate the arteries, trying to reduce shear stress back to normal. This total decrease in systemic vascular resistance thus causes acute fall in both central and peripheral blood pressure, and then leads to this downward spiral that then ultimately causes your subacute and chronic changes, and this downward spiral being activation of your sympathetic nervous system. By activating this, you're going to have an increase in neurohormonal alterations, being an increase in your RAS system, an increase in your adrenergic system, and then an increase in excess ADH hormone. All of this ultimately leading to an increase in blood volume that's going to then further cause your heart some problems. And so that's the acute phase. Then moving into the subacute phase and chronic phase, it's just the play of your heart pumping against no resistance at all and then having an increase in blood volume causes ultimately a couple things to happen. You have basically greater venous return that increases your right atrial, your pulmonary artery, and then your left ventricular end diastolic pressures that then in the course of weeks to months, now moving into our chronic phase, causes our heart to try to compensate. And so the way that it does that is first, your right side of the heart starts to dilate out a little bit. It's not being able to handle that volume appropriately. And then as that blood volume is trying to get through, your heart is trying to push a little bit harder in order to get that blood volume to move. And so your left ventricle starts to hypertrophy a little bit. It starts to get a little more thick. And so in that setting, your right side dilates out, your left side gets thicker, and you're trying to pump the volume that your body can't handle, thus leading to the chronic stages that we see in this high output heart failure type state, because all of this being is your EF is going to stay the same. And that's why we kind of say that this is this normal cardiac output state against this low SVR. And so that's a lot to talk about and a lot to think about in these kind of different phases. But ultimately back to the clinical kind of side of things, and what you're going to be doing in the emergency department is you're seeing a patient coming in who's dyspneic, who's showing signs of volume overload, but is kind of warm and well perfused peripherally. And so you being the astute and great resident or clinician that you are like, oh, this definitely could be high output heart failure. And so in that setting, you're going to go over and you're going to do something called the Nicolas-Brahman sign. Yeah, I'm sure we all know what that is. But just as a review, I'm going to go back over that again. And so what you basically do is transiently occlude the AV fistula site, which I know sounds really scary because the last thing I want to do is go over and mess with someone's AV fistula site, but this is something they do in clinic all the time and I assure you is safe. you take your sphygmomanometer, your blood pressure cuff, and you put it over the AV fistula site, and you crank that up about 50 millimeters of mercury above their systolic blood pressure, and that will transiently and maximally occlude the AV fistula site. And so when doing this for 30 seconds, what you're basically going to see is either one of two things. You're going to see bradycardia, or you're going to see an increase in blood pressure. And so ultimately, by seeing one of those two things, that sign shows you that that shunt is significantly contributing to your cardiac workload. And why that's important, we'll kind of get to in a little bit when talking about management of these patients, but it's a quick test that you can do at bedside that's easy, takes 30 seconds, as we can see by the Nicolas Gonzalez sign, and something that's going to really hint you into this diagnosis.
Okay, very good. Now, just to make Dr. Lewin proud and to ensure that you're ready to graduate, let's go over some of the other textbook signs that we might see in these patients.
Absolutely. Again, being the astute resident, the astute clinician that we are, some of the other physical exam findings that we can see, there's a bunch of different names for them. The big two ones in literature that I've seen and more so people have written about is something called Quincke pulses. And so what you'll see is nail bed capillary pulsation. And that's again called a Quincke pulse, in case everyone forgets. And then the second one being a Traub sign. And so that's classically described as forceful shot-like sounds over your femoral arteries when auscultating the fem arteries, which I know all of us, again, are doing on our physical exam. Thank you, Dr. Lewin.
Okay, excellent. Now, we're done with our exam. We're moving on. We're grabbing our ultrasound machine, and we're moving forward with the rest of our workup. Tell us what we should be looking for on POCUS and what else we should be ordering for our workup to help clinch this diagnosis or point us in the right direction.
When it comes to POCUS, one of the tools we should all be using in the emergency department, especially in the setting of these acute distressed patients, in the acute phase, what you're most likely going to find is a hyperdynamic LV. They're trying to pump, they're pumping normally against this decreased SVR to try to maintain the normal cardiac output. And then as you basically start to get some of the cardiac remodeling secondary to the increase in blood volume, what you're going to see is maybe more structural changes with left ventricular hypertrophy and maybe potentially right ventricular enlargement. And then ultimately, what you could be measuring as well at bedside is signs of volume overload with left atrial dilation and a plump IVC, which we could all be doing on basically rush exams anyways, and it's just a quick little maneuver over in order to check that IVC. And then further kind of working this patient up, you're going to see your lab values like an elevated BNP, showing that your body's kind of responding to this increased volume. And then lastly, and the most important thing when it comes to the evaluation of these patients, as we were kind of describing before, is finding and evaluating the underlying cause. And so you're going to be maybe seeing elevated TSH levels, maybe decreased thiamine levels, maybe they're anemic, maybe they have worsening liver function, and all of these things pointing to your underlying diagnosis and ultimately the reason of why they're in this pathophysiologic state.
Okay, Nico, now let's say we've identified the cause. How does this change the management for these patients? I would say that normally with heart failure, we're reaching for diuretics, or if somebody has fluid in their lungs or dyspneic, they're hypertensive, we're worried about flash and we're reaching for nitro. But how do we process it here? What applies here?
Yeah, absolutely. And I'm happy we made the comment on nitro, just because it's one of those things that this is the time to maybe back up and don't hit the nitro, don't pull that card right now. Just because we got to remember, right? I think classically we're acute respiratory distress, you're hearing rails, maybe you're seeing beelines all over, they're hypertensive, you're going to be thinking, oh my goodness, this could be flash pulmonary edema. Let me get nitro. Let me get one of these vasodilators. But again, if you're seeing a patient like this and has an AV fistula site, you should be thinking about high output heart failure. And so the problem there being is that they're already in a SVR state that's pathologically low. And so by giving them a medication like this, you're further going to drop it and tank them out, which could ultimately lead to a lot of deleterious effects. And so this would be the case to maybe hold off and really watch and be careful of that medicine. And so when reading the literature and kind of doing a little more reading behind this, I found that the first line mainly is medical management. And so what I'll say here is I'll put an asterisk on medical management just so we don't think about the nitro anymore. And I'll put it more so towards volume management. A lot of these patients, first and foremost, will get aggressive diuresis, and then ultimately maybe more so aggressive HD and ultrafiltration. But what happens a lot of times, again, as these patients move into the subacute phases and chronic phases of their underlying pathophysiology, maybe that's not enough. And just like we saw in our patient, in this patient scenario we were thinking about, where they were coming in acute respiratory distress, despite getting HD that very morning and getting a full session, they're still dyspneic and they're still suffering from disease. And so when that happens, you kind of have to move more into kind of our refractory management in the setting of your AV fistula. But again, let's go back and think about the underlying cause for other patients as well. And so when it comes to medical management there, maybe transfusing them, treating their underlying anemia, maybe giving them thiamine to treat underlying beriberi, and then maybe beta blockers or antithyroid meds for patients that are in our thyrotoxicosis type states. Now, going back to our patient scenario, the AV fistula site, we've done HD, we've done the things to get the volume off, but they're still dyspneic, they're still symptomatic. Now we move into our refractory cases. And when it comes to this, the first step in management would be maybe closing unused AV access sites. A lot of these patients will go through many different sites in order to get a site that works best for them. And ultimately, maybe sites that stopped working as good, they'll get new ones. And so in these patients, what you can do and what they'll do basically in our subspecialty services is close the unused sites. By doing so, what's going to happen is you're going to try to increase your SVR by decreasing flow through those sites. And so that's more so, I would say, this approach of conservative management. Let's try to save their one good access site. But unfortunately, in a lot of these patients, that might not be enough either. And so that's when we move into the next phase of management. Here, we have one access site. That's what I want to think about now. We have only that one site that's working. And so we got to try to preserve that as much as we can. By doing so, what we can do is reduce blood flow through that fistula site. By reducing the blood flow through it, you're going to decrease the shear wall stress going through that site and ultimately decrease the systemic effects that the fistula site is causing in specific. And so the idea is, again, by reducing the systemic effects, you're going to overall increase that SVR again and maybe help out the entire disease process to begin with. Now you're getting into the weeds of how much you're reducing that by and what you're doing to do so. There's different procedures. There's either banding procedures, there's Rudy procedures, which is basically a revision using distal inflow, which is a little bit more complex than what we need to be thinking about from an emergency standpoint. But the goal here is to reduce blood flow through there. And that's kind of what I want us thinking about.
Okay, Nico, on top of the cards, we touched on tox, we touched on endo. A lot of ground has been covered here. Let's distill it down. Why don't you give us some rapid fire take-home points that we should all keep in mind?
I think the first and foremost thing that we need to be thinking about is, how do we identify these patients, right? What do they look like? And so that's the first key. Dyspneic, but warm extremities and a wide pulse pressure. That's what we got to be thinking about. You see that, you got to be suspecting high output heart failure. The next thing being is not trusting a normal ejection fraction, right? A normal EF of 50 to 60% doesn't rule out heart failure in these patients. We have a normal cardiac output against a low SVR. That was the definition we set in the beginning, and that's what we got to think about. The next thing being is check the access site. Don't be afraid to do physical exam maneuvers. Nicola, Donnie, and Brahman set out and did all their research studies for you to go out and do this maneuver, and so you got to try it on these dialysis patients. And then finally, the last thing being is hunt for the cause. Get the underlying answer. This is a disease process, not a disease in and of itself. You have to find out the reason of why they're here and why they have these symptoms going on. And so if you don't look for it, you're never going to be able to treat it. Look at the fistula, order the lab tests, and ultimately get that diagnosis.
Excellent, Nico. Thanks for being in the studio with us.
Yeah, thank you so much. This is awesome.